for this series. I think it's been exceptionally well conducted and well attended webinar. Almost all the indexed surgeries and the topics have been covered. Now today's topic is on carotid artery disease. As we all know, next to cardiac problems and death, stroke is the second cause of not only severe morbidity with all over the world, if you look at globally. And as we again know, that 20 to 40% of ischemic strokes are related to the internal carotid artery stenosis, of course, which has got an extension into distal common carotid as well. So now we have 3 talks lined up. Number 1 is the decision making, which is very critical. Whom to be operated, whom to be selected for stents, how to prepare them, the post-operative situations, all that I think we are waiting for Vineet to say. The decision making is very critical. And we have, as we know, 2 complementary procedures, carotid endarterectomy and the carotid stenting. Both are vibrant procedures, I would say. World over, these 2 procedures have made great in preventing stroke. Carotid endarterectomy by removing the the plaque which is what do I call that, the plaque, sorry. Okay, we know that offending plaque can be removed and we can put a patch and improve the carotid flow and the brain blood supply, where in contradiction, the stenting, what it does, it fixes the plaque, offending plaque, and jails it using a stent, and we dilate and improve the carotid circulation. And one thing to be underlined is that it's not the blood supply requirement, but the problem offense is done by the atheroembolism or the rupture of the plaque or the clot getting into the brain, producing an acute obstruction and stroke. So that is what the problem with the carotid plaque. So I think now we have 3 speakers. I'm sure he's getting ready for the decision making, and followed by
hi sir, good evening. Sorry for the delay. Actually,
no problem. I think you can, Vineet, you can go ahead. No problem. Not much delay. You can start your presentation.
Actually, I'm not able to load my presentation, so I am sending it to Siddharth by mail, and I'll be talking through phone. So
okay.
Right now I'm sending it through mail.
Vineet, what happened?
I don't know. Zoom meeting, that app is not working in my laptop. I logged in through my phone. 1 second, I'll try. 1 second.
I made you the co-host.
He's in his phone, sir. He may not be able to present with the phone. Vineet, you can send it over. I think it'll be easier that way.
Yeah, I'll send by mail.
Okay.
So by the time Vineet is sending presentation, a few words of VASK. VASK has started this session to initiate a propagation of knowledge of vascular diseases among the general practitioners, among the other specialties. Because even though there are a lot of diseases, for example, carotid is it's a very common problem in patients with stroke. Many people are not looking at carotid disease as such. Even we are doing a stroke program in medical college at present. It's a pitching state, but even then, when we look at patients admitted with stroke in medicine wards, even at AK hospital, people are not doing any Doppler for the carotids. So such a situation is prevailing in the medical community as such. They are not looking at even the pulses or even the vascular diseases. Even many of the surgeons don't do a Doppler before doing an amputation. Such a situation is existing. So just to have spread the knowledge of vascular disease. So somehow we have succeeded in spreading the knowledge because some sessions were very good. We have got attendance more than 150 in some sessions, but in March sessions were little less attendance. Anyway, it's a good initiative. We are winding up the session today with the carotid. maybe another, maybe after the COVID and all, we will come back with another session of vascular diseases like this, so that we can educate our community, medical community, regarding vascular diseases. I thank each and everybody for making this a big success. My secretary, Dr. Vimalai, has done a wonderful job for mobilizing the sponsorship, all thing. Sunil has done a very extensive job for selecting the faculty and organizing this thing. And Dr. Siddharth also have this organizing the session as the session coordinator. Shiva has organized the quiz program, and we have given prizes, quiz program prizes for every session. It was well accepted by many of the residents. So, and also I thank the IMA Trivandrum for sparing their Google Zoom platform for conducting the session. So we, on behalf of VASK, welcome you all and thank each of you for supporting us for conducting this session. And with these words, I hand over mic to Vineet to have his lecture. Vineet, please. Vineet?
He's probably still trying. So I think then while we're waiting, I'll publish the quiz results of the last session. So I'll just quickly share my screen. So last session, session 9, was on mesenteric vascular disease, and we have two prize winners. One is Dr. Apurva Krishna. She's a DNB vascular surgery resident at NIMS Nizam's Hyderabad, and there is the second winner is Dr. Shankar, who's a final year resident at GI Surgery Department in Amrita Institute. So we congratulate both the winners, and they win a prize money of rupees 2,500 each. We'll have a similar quiz for today's session as well. The quiz link will be posted at the end of the talks, and I request the participants, attendees of today's session, to kindly go ahead and attend the quiz and stand a chance of winning this prize money. So thank you. I think we are still waiting for Vineet to send me the link.
Sandeep, you are there? Nisams?
Hello, sir. Good evening, sir.
Good evening. Congratulations. Your resident has got 2,500 rupees. After COVID, you can
Thank you,
have
sir.
a party
Thank you.
there.
Thank you, sir.
After COVID, you can have a party there.
Sure, definitely, sir.
Okay.
Quite encouraging.
Muni sir, shall we think of going with the second talk just to get the...
So shall we start with Satvik then?
Yeah, how long does Vineet take, if we can? Because
Not sure, sir. He's trying. He's not yet come back with the... it takes some time, looks like.
Yeah, because the sequence
would have been with that,
decision making and then go for the interventions. Then we have two strong speakers, Satvik on intervention and Shivanation for open surgery. So it becomes a little the horse behind the cart.
Siddharth sir, can you hear me?
Yes.
Yeah.
I sent you the presentation.
Okay.
You can.
Hasn't come. You sent in the mail?
Yeah.
It's the webinar mail or my mail?
Your personal mail.
No, I've not received it.
Sorry. Patient is not.
Again sent.
Spelling is correct because I've not received it actually. Just check again.
Yeah, just check, sir, your personal mail.
It's not come.
Siddharth, you can start with
yeah, it's come. It's come. It's come.
one more thing, for the benefit of the residents and the teaching faculty, we are planning for a vascular PG clinics, maybe after 1 or 2 months when the COVID is lessened. We will have some vascular PG clinics on arterial, venous ulcerations, aneurysms, some case discussion like with including with national faculty. So I request all the residents and the teaching faculty to spread the message that we will inform you all with separate e-brochures, maybe after the COVID is little settled. Yes, Vineet, please start.
Good evening. Can you hear me? Am I audible?
Yes.
Yes.
You are audible.
Okay. Thank you, sir. Thank you, Utti, sir. Thank you, VASK senior faculty, for giving me an opportunity to present in this a wide platform. This is my first presentation after becoming a consultant in this VASK meeting. So thank you for including me in this family. And I'm really honored to be share this platform with Ambarish sir, who is also my teacher for this endovascular aspect. Hi, sir. I hope you can hear. And my teacher, my mentor, Shivanesan sir, is there. So anyway, sorry for the delay due to rain and all this. Some net issues are there. So right now I'm starting. So my topic is decision making in carotid artery disease. So when to intervene. So coming to next slide. So before when to intervene, I start with whom to intervene. Suppose next, any patients comes with any of these symptoms like unconsciousness, tonic activity, dizziness, vertigo, dysphagia, dysarthria. We should know that you should not intervene these symptoms, because these symptoms are not at all related to the carotid territory, because they are vertebro-basilar deficiency. So next please. So these are the symptoms pertinent to the carotid territory whom we have to intervene. So mainly TIA and stroke. Next slide. So after when the patient coming with these symptoms, next best thing to do is we can straight away, next slide, we can best start with a best medical treatment, irrespective of the degree of stenosis or symptomatic or asymptomatic. So best medical treatment, next slide please, includes basically a single antiplatelet along with antihypertensives, diabetes mellitus control with HbA1c target not tight. It will be like less than 7, not 6.5, according to that ACCORD and advanced trial. Then the smoking cessation, statin therapy with a target LDL of less than 70, and avoid alcohol excessive consumption. So this can be the next thing. So in addition to the BMT, whether any intervention ought to be done in addition to BMT is based on 3 factors. One is we have to know the future risk of stroke of that patient, then the patient related factors and procedure related factors. Next. So how to estimate the risk of a stroke for a particular patient? Next. The most important predictor is the presence of stroke within 6 months. 6 months. That is symptomatic patient. This history of stroke is the most important predictor that this patient will get a future stroke. Next. So next best thing is identify a silent emboli. Next, calculate the degree of stenosis and type of plaque. So what is the evidence for this? Next. So we can see that these are the 2 groups of trial. One is for the symptomatic patients, other for asymptomatic. So we can see that the percentage of stroke is higher for symptomatic patients. That means those patients having prior stroke has high risk of future stroke. with BMT when compared to asymptomatic patients. So that is why prior stroke is the most important predictor. Next slide. Then next step is to identify a clinically silent emboli. So how to identify emboli? Next. Either we can do a CT or an MRI and see whether an infarct is there, prior infarct, or next, or we can look for high intensity signals in transcranial Doppler. But that is not practical because TCD is the 10% of cases, the window may not be there. It is not standardized everywhere. So the TCD may not be practical. So next best thing can be done is to calculate the degree of stenosis. So first we have to do a duplex, and based on the PSV, we calculate the degree of stenosis severity and group it into less than 50, 50, 70, more than 70, and near total occlusion. Or we can do a CT angiogram and calculate the degree of stenosis. So that is either by two methods. Either we go by NASET or an ECST. So next important factor to predict the future risk of stroke is plaque progression. If suppose a patient plaques, the stenosis is progress from less than 50 to more than 50%, is a very important predictor of future stroke, and we have to intervene. Next is plaque character. Here comes the term vulnerable plaque. Vulnerable plaque is nothing but a plaque prone for embolization. So vulnerable plaque can be predicted, identified. Based on duplex, we can see if we are a good sonologist, we can identify the hanging thrombus there. Or using an MRI recently, we can characterize the interplaque. And this is the morphometry of the plaque with a latest ultrasound with a 3D. Or the more advanced PETs can also be used. So next is when to intervene. So basically, to summarize, there are plaque-related factors and patient-related factors. So plaque-related factors we will get from all these above investigations, and basically the stenosis as well as ulceration, the progression of the plaque area, and also the patient-related factors. And among the patient factors, the prior neurological symptoms is the most important predictor. In these patients, so this is summarized in ACRS study. So these group of patients, so ACRS has grouped the patients into two categories with symptomatic based on the plaque characteristics so that it predicted the future risk of stroke. So coming to the second important point, previously we based on the above all these factors, we can predict the future risk of stroke in a patient. Next year, what are the patient-related factors affecting the decision for intervention? So they are basically life expectancy. All NASET, TCST, ACAS said that only patient who had a life expectancy of more than 5 years need to be intervened, expectancy of 5 years. Next, age, definitely, that is high risk of stroke after CAS beyond 80, but not for endarterectomy, old age. Gender, females, high risk of stroke. Then functional status, suppose patient having dense neurological deficit, that is new stroke scale more than 20, definitely we should not proceed with intervention. Then cardiac status, high risk of MI, any decompensated, high risk for endarterectomy. Pulmonary disease, high risk for CEA, and renal insufficiency, high risk for recurrent re-stenosis. And not last, but contralateral carotid occlusion. From recent SPS registry, it was told that there is increased risk of stroke during endarterectomy if the patient is having contralateral carotid occlusion. Next comes the procedure-related factors affecting decision for intervention. So there are 3 procedures we do for carotid to prevent stroke. They are basically, one is carotid endarterectomy, second carotid artery stenting, transfemoral, and the newer one is TCAR. So the procedure-related factors during endarterectomy is, suppose the patient having congestive heart failure, left ejection fraction less than 30, unstable angina, recent MI, or local factors like prior radiation to the neck or previous cranial nerve injury. These particular patients are considered as a relative contraindications for doing endarterectomy. And what are the procedure-related factors for CAS? So basically the type of aortic arch. There are 1, 2, 3 arch is there. So in type 3 arch, whether if all the major vessels originate below the horizontal line, then there is high risk for complication during procedure like sheath slipping and cannulation problems and all. This is what is called the shaggy aorta, where there is considered as a contraindication for CAS. Next. This is carotid string sign. A very narrow luminal flow will be there. So there is high chance of stent non-expansion and future risk of stroke. And high tortuosity of the ICA. So to summarize, what is the evidence is like for the symptomatic patients based on NACET and ECST, more than 70% CEA is beneficial. For asymptomatic patients, more than 60 patients, CEA is beneficial. So to summarize all the societal guidelines, when if symptomatic patients, if he had carotid stenosis less than 50% or an asymptomatic patient with less than 60, should not undergo any intervention and should be put on best medical treatment. If symptomatic patients more than 50%, CEA is preferred over CAS in all societal guidelines. In symptomatic patients, if they are high risk for CEA, then CAS is preferred. If at all, we have to do intervention within 2 weeks for symptomatic. In asymptomatic, more than 60%, CEA is preferred. And if asymptomatic patients are high risk, then better not to do either CAS or CEA, put him on best medical treatment. In case of chronic total occlusion, intervention is not indicated. Thank you.
I think, Vineet, that has been an extraordinary presentation. You have dealt with situation, classifying them into plaque-related and patient-related, and very well brought out. I just wanted to add one thing. You already mentioned that after duplex, there must be a confirmatory investigation of CT scan for many reasons. Confirmation, presence or absence of lacuna infarcts in asymptomatic. Another thing, there is a small catch in duplex scan in case the patient has got 1 or 2 episodes of, say, TIA, and duplex says occlusion. Do not take it blindly. I think a CT is required because a 98% or above stenosis, even 97, duplex will mention almost occlusion. So if you are clinically suspecting, clarify with a delineate with a CT scan, must do. Of course, anyway, we are going to do it. So don't go by that duplex scan saying that it's already obstructed and then there is no point in doing endarterectomy. It's not like the total occlusion and no artery is seen extracranially.
Yes,
then
sir.
Other thing is, although you have mentioned symptomatic 50%, I think that group of patients would require maybe 3 or 6 months of best medical management before we choose for one treatment. Personally, I feel 70% will be the better cutoff point for taking up patients for intervention. I think that has been the teaching we used to teach and we used to do. But I think at the present time, I am personally not going to change to 50% because if you give the best medical management, which is part of standalone therapy or following intervention, stenting, or endarterectomy, the best medical management has to be continued. You give this for 3 months, the chances are that 50% around, it can come down to 40. It may stabilize the plaque and you don't have to do any intervention at all, because at 50%, chances of more complications like atheroembolism and ischemic changes are going to be there. So that is one personal, whatever resume from my number of 295 carotid endarterectomies, still I would not do at 50% unless there is a crescendo TIA coming up. On treatment, 3 weeks, 4 weeks, if he continues to have, that is different. It could be an ulcerated plaque. Otherwise, I would still stick to the gold standard 70%. I think, Vinay, that's a wonderful presentation.
Thank you, sir. Thank you.
All the details. It's a very, very good. Very, very good.
Thank you, sir. Thank you.
So shall we move on to the next talk?
Yeah. I think Dr. Sathwik will come up with the carotid stenting. I think he's widely experienced in this art form. Whereas, you know, of late, I have not heard any presentation of stenting, because personally, I strongly believe carotid endarterectomy is the first, second, and third option for carotid disease, except specific settings. Okay.
Thank you, sir. Thank you very much. It's an honor to be on this platform, and good to see you, Vineeth. That was a lovely and crisp presentation, and
thank you, sir. Thank you.
I think you've set the stage for the subsequent 2 talks. My presentation will be on endovascular strategies in carotid disease. And I would completely agree with you. Look, I'm not here in any position as an advocate for carotid stenting. In fact, as we will proceed through my presentation, you will realize that my preferred procedure is also carotid endarterectomy, which I think is the gold standard for management of extracranial cervical carotid artery disease. But there are definite indications for carotid artery stenting. And I'll just take you through some of those indications, some of the pitfalls, some of the contraindications, and perhaps a few technical details of carotid artery stenting. So with the permission of Dr. Unnikrishnan, if I might begin.
Yes, please. Go ahead, please. Go ahead. Yes.
So I'm going to, I was told that many of the participants on this seminar are not necessarily vascular specialists and might be neurologists or other physicians. So just for the benefit of those people, I'm going to show you an animation of carotid artery stenting, just so that the non-vascular specialists can have some idea about what the procedure looks like. Now, the carotid bifurcation usually is beset by a plaque, and actually in many instances it looks as nasty and friable as that. And this procedure is performed. We first cannulate the common carotid and try and negotiate the wire into the external carotid safely, get the sheath in, and then cross the lesion. As you can see, that first crossing can also be fraught with a lot of danger because you might just dislodge the debris. Then you take the wire into a straight portion of the distal internal carotid artery. And subsequently, and I'm just going to pause this, almost all cases of carotid artery stenting are done with an embolic protection device, such as the one that is being demonstrated in the animation. This filtration device is deployed, and I'll show you the technical details of this later. Basically, what this is it's a mobile filter that can be moved on a bare wire, which is usually 0.14 in diameter. And this wire, if I can just show you, so somewhere here, can you see the cursor on my screen as I'm sharing the screen? Can you see this as I'm moving the cursor? Is it seen? Yeah. So somewhere there is a small bead, which basically doesn't allow the filter, once it's open, to go distally. So this is that bead right here. So the filter cannot migrate beyond that point. And once this filtration device has been deployed, then you can pre-dilate if necessary. This is pre-dilatation. As you can see, some debris is escaping, and this is going to be successfully captured in the filtration equipment. And subsequently, a self-expanding stent is going to be deployed from the ICA into the CCA. And we will discuss details of this stent later on. After this, of course, any residual stenosis can be treated. We normally accept roughly 25 to 30% stenosis in the carotid. And during this post-dilatation also, you can see some debris is likely to escape, and it will be captured by the filtration element. And then this is a filter retrieval device. And you can see that the filter closes onto this filter retrieval catheter, partly, not completely. And then you can either remove the filter retrieval catheter separately or with the wire together, and then take a check angiogram to make sure that you've treated the stenosis successfully. It's best to do a 4-vessel cerebral angiogram prior to the procedure, before starting the cannulation, before crossing the lesion, and also after you've completed the angioplasty. So that briefly is what the angioplasty procedure looks like. And this has changed the outcomes for carotid artery stenting. This is the filtration element. And this will give you, this is a sample filtration element. This is from Abbott. And you can see this is a nylon material with very fine pore size of 120 microns. And the scaffolding is usually collapsible. And it is collapsible when you basically take a catheter, a retrieval catheter, and collapse both the scaffolding and the nylon element as you advance it over the filtration element. Now, as we all know, the success of carotid artery stenting, the great success story of carotid artery stenting, commenced after the results of Crest were presented. And it's been more than 10 years that the Crest results have come out. And just to give a very brief summary of the Crest trials, very, very briefly, about 2,500 patients were enrolled, 108 centers in the US, 9 in Canada. And what they found was that more or less there was parity between both procedures, both carotid artery stenting and carotid endarterectomy. The primary composite endpoint was that of stroke and death and myocardial infarction. And what the trial finally established was that there was parity in that the composite endpoint was the same, both for carotid artery stenting and endarterectomy. But when the results were dissected further, it was found that in the group which was stented, the rate of periprocedural stroke and death was higher. And in the group that was subjected to carotid endarterectomy, the rate of myocardial infarction was higher. What was strange and interesting was that the definition of myocardial infarction included enzyme leaks. So just a raise of myocardial enzymes was also perceived as myocardial infarction. So it was slightly skewed against carotid endarterectomy because it was just taking raised enzymes as evidence of myocardial infarction. But when you're fundamentally doing a procedure on the carotid artery, what you're worried about is not an enzyme raise after the procedure. You're worried about periprocedural stroke and death because it's primarily a stroke prevention procedure. So in that, carotid endarterectomy was the favored procedure and not carotid artery stenting. But nevertheless, the composite endpoint of stroke and death and myocardial infarction, both procedures showed parity. So carotid artery stenting took off wildly after that. And many people started performing these procedures. Now, currently, what we follow as regards guidelines for carotid artery stenting or even endarterectomy, as Vineet pointed out, are basically summarized in this document. This is a 2017 clinical practice guidelines document for ESVS, which I think is the best representation of current practice and best clinical practice. It was published in 2018, and it was stewarded by Ross Naylor, who is one of the finest exponents of research on carotid artery disease. And this is fundamentally the flow chart and the algorithm which is followed. And I completely agree with Professor Unnikrishnan when he says that minor cases of stenosis, which is about 50%, are usually best left alone. So if you will just go through this, you will realize that you obviously, apart from duplex, you need some sort of imaging, which is angiographic imaging, either CT angiography or an MR angiography or a DSA. And one of the reasons, apart from actually giving you a complete idea of the neck anatomy of the carotid, it will also give you an idea about the patency of circular Willis, because that will also be an important deciding factor when you pick and choose what procedure to do, or other decisions such as clamping and so on, and shunt placement and other things. But apart from intraoperative decisions, but definitely a neck and brain angiography is mandated before you should touch a patient of carotid. I know the NHS sometimes would not always do brain imaging, angiographic imaging in these patients, but I think we've been adhering to this practice and it's served us well. So obviously you will either be in a situation where the patient is symptomatic, which is on the right side, or asymptomatic. Now, asymptomatic patients have incidentally been diagnosed as having carotid artery disease. They've suffered absolutely no consequence. So they're sacred. And you have to be very, very careful and confident before you touch them. And usually it's best not to interfere. And if you ask me personally, I wouldn't touch a case of asymptomatic carotid artery disease unless it's more than 80%, and that also after very carefully and personally evaluating the plaque morphology to make sure that this is indeed a vulnerable plaque, and that the patient has a life expectancy of more than 5 years, and that the patient has favorable anatomy either for surgery or stenting. And I usually wouldn't want to stent these patients. I would rather do surgery if at all it's high-grade asymptomatic carotid artery disease. And for symptomatic, obviously, you are more liberal in treating them because more than 50% you are justified in treating them. But as I will just show you this will tell you how you gather this evidence and what level of evidence it is. So if you're touching carotid artery stenosis more than 50% to almost 69%, this is class 2A, which is basically, and it's B evidence, which is data derived from either a single randomized trial or large non-randomized studies. Okay, and usually, even in these cases, even in symptomatic patients, for 50 to 69% stenosis, you would rather subject them to endarterectomy and not stenting, because the level of evidence and the class of evidence is better there. And of course, there is no dispute that this is the area where a wide variety of your patients will be showing up, which is basically symptomatic more than 70% stenosis. And here again, endarterectomy is class 1A evidence, and stenting is class 2A evidence gathered, which is of B level. So clearly the winner here is definitely endarterectomy, there's no doubt. But of course, a subset and a select group of patients should be referred for carotid artery stenting, and I'll tell you which ones are those. Now, before I go on to the nitty-gritties of the procedure, I'm quite fond of subjecting research to Bayesian analysis, which is a kind of long-form research. And what that means is this is an interesting table, which will tell you that based on all the evidence we have from all these trials on carotid artery stenting. So this is entirely about carotid artery stenting. Let's say Sapphire was a trial that actually favored carotid artery stenting. So let's say you go in as either a strong advocate for stenting, or you go in as a strong skeptic for stenting. You're very, very suspicious of stenting. If you are, for whatever reason, at true equipoise, which means that you are undecided whether the patient should be subjected to stenting or you are in favor of stenting, what happens as you gather evidence from all these trials? And you will see that as evidence has been piling on through all these trials, let's say in 2004, you were at true equipoise. So you weren't decided whether you should go and subject your patients for carotid artery stenting or not. Over the years, as evidence has been mounting, if you started off at 50% faith in carotid artery stenting, so 50-50, you're at true equipoise, right now you're at 9.3. That's how the Bayesian analysis has progressed. So confidence, if you look at scientific evidence in carotid artery stenting, if you were to look at these things objectively, the evidence has been such that any person at true equipoise, which is 50% in favor of carotid artery stenting, would fall to 9.3% in favor of carotid artery stenting. And my own belief in carotid artery stenting is more or less on these lines. Now, if you were to ask yourself, what level of evidence would it now take? Now, even the Crest data was released in 2010. It is 2021. What level of evidence would it now take for you to rise from 9.3% to 50%, which is true equipoise? What kind of a trial would have to be conceived so that your confidence grows in carotid artery stenting? Now, it's very strange that that kind of a trial will have to enroll roughly 4,000 individuals in each arm of the trial and get results in favor of carotid artery stenting for your confidence to go up from 9.3% to 50%. So clearly, you know my bias. I'm not in favor of carotid artery stenting, and I completely subscribe to Professor Unikrishnan's view on carotid endarterectomy. But having said that, we will now move on to other things. Now, where do you have to be careful when you're doing carotid artery stenting? Is there something like hostile anatomy for carotid artery stenting? What does the Crest data tell us on poor outcomes, which is acute ischemia following carotid artery stenting or acute periprocedural stroke following carotid artery stenting? And the Crest data tells us that there were two conditions where results of carotid artery stenting were not very good. First, if there were contiguous lesions, okay, which were sequential or non-contiguous, which was separate, which is two lesions in tandem, and a carotid artery stenting was attempted, that in those cases, outcomes were not particularly good. So anatomy looked something like this. This is a long kind of in tandem lesion, you can see. Look at the length of these lesions. Or conversely, contiguous lesions. So there's one lesion here and another lesion here. And outcomes in such cases, like the other ones here, outcomes in such cases were not particularly successful. So this is what the Crest data tells us about where to be careful when you're trying to do carotid artery stenting. Also, we have now, subsequently, post-Crest, we've got a lot of work on anatomical considerations about when to intervene, when to perform carotid artery stenting, and how careful you have to be. So obviously, the first thing is aortic arch angioarchitecture. So this is how the procedure is carried out. You usually go through the femoral route, and you take in either a guiding catheter or a long sheath, a 90 centimeter sheath, and then you enter the common carotid and first park the wire into the external carotid. Then you exchange that wire with a stiff wire, get your sheath in to the common carotid, and then once your sheath is in the common carotid, you withdraw this wire and try and cannulate the, try and cross the lesion. So now if you're going in from the groin, you've got one curve of the aortic arch, and then you've got another curve through which you have to get into the common carotid. On the left side is still easy, on the right side is going to be even more difficult. So obviously, based on the arch architecture, you are going to have trouble. And sometimes you need these funny catheters to actually cannulate the common carotid if the arch is giving you trouble. And as Vineet had pointed out, Usually type 1 arches don't give you trouble, but type 2 and type 3 arches. And also you have to remember that someone at the age of 40 might have a type 1 arch, but as this person is getting older, the arch will sag and will end up with type 2 or type 3. And these, as you can notice, will be difficult to cannulate. So you'll need to actually, the bend and the cannulation is going to be more and more difficult as you progress from type 1 to type 2 to type 3 arches, or if it's a bovine arch with a common origin of both side carotids, is going to be difficult. And now you consider, if you're doing all this instrumentation and maneuvering of catheters, if there is plaque and atheromatous debris at the origin of these arch vessels, it's entirely possible that with every exchange and with every kind of manipulation, some of that debris might dislodge and you might give the patient a peri-procedural stroke, an intra-procedural stroke. So the more complex the arch is, you might be well advised not to fool around too much and perhaps subject this patient to carotid endarterectomy. Look at this. This is, and this isn't uncommon in the elderly. So this is a nightmare if somebody's trying to do a carotid artery stenting for the right ICA in this patient. And you might need these funny catheters. These are special catheters which have been devised for type 3 arches and bovine arches, which might give you access. But as I said, pick and choose your patients very carefully when you've got difficult arches. Which asymptomatic patients to consider? As I said, I'm very, very careful with asymptomatics. These are sacred patients. They've never had any neurological problem in their life. The plaque has been incidentally detected. You cannot afford to give them any stroke. So the ones that you should consider should be this. A, you've got contralateral carotid occlusion and preferably high-grade carotid stenosis, which might have progressed very, very rapidly. So sometimes what happens is that you've got a 55% stenosis. Sorry, you've got a 55% stenosis in the carotid, and you've been observing these patients every 6 months, and suddenly you find there's been an interplaque rupture, and this has progressed from 55 to almost 85%. So this is rapid progress. This is something you must watch out for. Echolucency of the plaque. The more lucent the plaque on ultrasound, that means it's a soft atheromatous plaque and a greater chance of being converted into a vulnerable plaque. Intraplaque hemorrhage. One of our students, DNB students, we had a dissertation for him where we did intravascular, we did ultrasound with contrast, microbubbles. And in case there is extensive intraplaque vascularity, these microbubbles will find their way into the plaque, and therefore in asymptomatic carotid patients, you can identify vulnerable plaques, that is plaques which have got extensive intraplaque vascularity. And also every asymptomatic carotid patient where the asymptomatic carotid stenosis has been picked up, you must subject them to brain imaging, because what you think is asymptomatic, you could find microembolization and microinfarcts in the brain, and the patient has never suffered any symptom, but you might find evidence of microembolization in the brain. And all these asymptomatic candidates should be subjected to carotid revascularization. If they're not fit for carotid endarterectomy, then they should be subjected to carotid artery stenting. So which are the other carotid arteries that you should ideally stay away from or prefer, conversely? So technically, the hostile anatomy would be if the angle between the ECA and ICA is obtuse, which means more than 90 degrees. Anything less than 90 degrees technically can be attempted. Obviously, as Vineet pointed out, there should be minimal tortuosity or no redundancy. And again, most importantly, the artery which is cephalot to the stenosis should be straight, this part, the distal ICA, because you'll have to park your filtration element in this part. And if you have a tortuous anatomy, it'll be difficult to park your filtration element there. This is again hostile anatomy. You can see the extensive redundancy. There's hardly any place to park the filtration element. and extensive calcium, because you might not be able to sufficiently dilate this, and the stent might not have enough radial strength to actually give you a very good lumen even post angioplasty. So such, and all of this will be clear when you've done a CT angiography. You will know what you're dealing with. Obviously, thrombus that is partly attached is a bad candidate for carotid artery stenting, but you have to be sure that it is thrombus and not calcium, as you can see here, and this will again be clear on CT angio imaging prior to the procedure. Ulcerations, again, bad idea, because no matter how strong your stent scaffolding is, it's always possible for the debris in the ulcer to escape through the struts of the stent and cause either a intra-procedural or post-procedural stroke. So ulcers, try and stay away from. What kind of stent should you use? Now, this is an echo-lucent plaque. As you can see that this is the narrowing. From here to here is the carotid. This is one wall of the carotid. This is the second wall of the carotid, and this is the plaque. And you can see that there isn't any calcium here. This is all echo-lucent, and you can see that this part is possibly intraplaque hemorrhage. So when you've got an echo-lucent plaque, you have to be careful with the stent structure that you're using. You can't allow, whenever you're going to do a dilatation, a pre-dilatation or a post-dilatation, this echo-lucent plaque, which is soft plaque, might actually migrate through the struts of the stent and cause distal embolization. So you have to use what is known as a closed cell stent. And this is the time when I will explain the difference between an open cell and a closed cell stent. You can see that the cells here are completely closed. And here the cells are open, and the cells are connected to subsequent rows just with small struts, which are strategically placed. So the open area for the plaque debris to migrate and cause distal embolization is much more when you're dealing with an open cell stent, and it is much less when you've got a closed cell stent. So if you've got a soft echo-lucent plaque, it's advisable for you to use the closed cell stent. If you've got a slightly more stable plaque, an open cell stent would be a better idea. But what is the advantage of an open cell idea? Because it's open cell, it's more flexible, and it will conform to the artery much better than the closed cell. The closed cell advantage would be less chances of embolization and better radial strength. So if you're dealing with a tenacious plaque, perhaps a closed cell stent would be better. And here again, it's the same algorithm that you follow. If you've got an echo-lucent plaque, use a closed cell stent, and otherwise an open cell. So this is the difference. You can see that this is, for instance, Abbott, which manufactures both open cell. This is the AccuLink, which is the open cell stent, which you can see that basically it's got rows of the stent with just 3 strategically placed vertical elements. This is an open cell. You can see there's much more openness in the cells, and these are closed cell stents. And you can see that both this is AccuLink, which is their open cell stent, and this is Exact, which is their closed cell stent. Both of them come in straight and tapered configurations. So the smaller part of the tapered bit will be in the ICA, and the broader bit would be in the CCA. Now, this is a hybrid stent, which I don't think is available any place right now. It used to be manufactured by Crystalone, which has got an intermediate, a central closed cell design, and both distal and proximal are open cell designs. So for better conformity in the distal ICA and the distal CCA, and more radial strength for the actual stenotic part of the ICA ostium. And this is the newer kind of stent, which is now being used in the carotid circulation. This is basically a nitinol or a flexible open cell stent with a micro mesh. So you don't technically need a filtration element. You just basically cross the lesion and without pre-dilatation, just deploy this and then post-dilate. This is, the pore size is so small that usually there is no distal embolization. One of the examples of this is called the Seaguard stent. And this is about conformity of the stent. As you can see, that you will have an open cell stent which looks much better, aesthetically looks better. It's conforming much more to the anatomy of the artery. But has limited radial force. So obviously more difficult and tougher plaques will not respond to this, but this is the closed cell design, which will conform much less, but will have better radial strength. And finally, I'm going to show you an angiogram. My apologies, this was very quickly gathered from the cath lab today because I didn't have time to convert them to AVIs, but this is just a sample of carotid artery stenting that we keep doing. This is the plaque. You can see it's an ulcerated plaque, very nasty plaque. Okay, this was a patient with low ejection fraction and was completely resistant to the idea of carotid artery stenting. Carotid endarterectomy, which is why she was subjected to carotid artery stenting. So it's an ulcerated plaque, tight lesion. And this is, the lesion has been crossed. And this is the filtration element which is being taken, which has been conveyed, and it hasn't been opened yet. And now I'll show you how the filtration element opens. Kindly pay attention here. There, you can see this. This is the filter opening. Okay. And usually we prefer doing these patients under local anesthesia, wakeful monitoring. And sometimes when you're going to be doing a pre-dilatation, the anesthetist will have to be informed because sometimes their heart might just stop or might lead to bradycardia. So sometimes glyco or atropine might be necessary, but I'm just going to show you the filter deployment again. This is the filter being opened up in a straight part of the artery. Okay. And this is the stent which is being deployed. This is the stent that has been deployed. And you can see that this requires post-dilatation. Obviously, the stent hasn't opened up. This is a tough plaque in the ICA. You can see this very compromised opening up, but because a filter is present distally, we'll be quite comfortable in doing a post-dilatation. This is the post-dilatation going on. Post-dilatation going on. There you go. And this is the angio subsequently. As you can see, the artery is opened up quite nicely. Yeah. And this is the wire and the filtration element being retrieved subsequently. So with that, I'll stop. I've already taken a lot of time. I have an animation video for TCAR. If anybody is interested, I can show it later. But it's not a procedure that has been, since we haven't done it, it's basically a flow reversal procedure. But having gone through the procedure, I find that if you are going to give an incision on the neck, you might as well do a carotid endarterectomy. So I'm happy to, in case the participants are interested in learning about that, I'm happy to show an animation of the procedure and we can discuss it later in Q&A. But thank you for your time, sir, and your patience. And back to the chairman. Right. So I think you're on mute, sir.
Can you hear me now?
Yes, sir.
Okay. So as I said, you made a masterly presentation and delineating all the good and little bit of bad problems with the stenting. And of course, the carotid endarterectomy and stenting, they are, complementary procedures, and you could choose the right procedure, patient-centric, what is needed. So I think before we go for more discussion, I thought we will listen to Shivanation about the carotid endarterectomy. Then we can make some comments and questions then. Can I call Dr. Shivanation for his presentation?
Yes, sir. So my audio is audible, sir?
Yeah.
So good evening, everyone. Respected chairperson, Unni sir, and my VASK colleagues. And I'm happy to be part of this last session on carotid endarterectomy. And the topic I have been given is whether open carotid revascularization is still the gold standard technique. And I like to thank Ambrish Satvik sir for almost more. There will be a lot of overlap between my talk and what he has showed. And actually, he has already made a point that carotid endarterectomy is definitely superior. So I just have to add few more points to this to substantiate the statements. So based on whatever the studies we have, so basic two things what we know is carotid artery stenting is associated with more perioperative neurological events, and carotid endarterectomy has more perioperative cardiac events. And this has been shown especially in the Crest trial and also in other trials also. I will try to show why this happens and how to choose a particular patient, whether he is fit for CE, carotid endarterectomy or carotid artery stenting. So carotid endarterectomy started almost now 70 years back. So almost we are reaching 70 years now. The first reported revascularization is done by East Coast, but the first successful endarterectomy was done by DeBakey in 1953. So since then, we have refined the technique. A lot of many techniques have come, and various shunting, without shunting, patching, so many controversies there. And almost like now we know what are the clear-cut steps of carotid endarterectomy, and it is really well defined. So I will go through the salient steps of carotid endarterectomy to show why it is superior than carotid artery stenting. As we know, this surgery is done either under a local or general anesthesia. It is usually done when we expose the carotid along the anterior border of stenocarotid mastoid, and once we expose the carotid sheath, we take the control of common carotid artery, internal carotid artery, and external carotid artery. So I just want to point one thing: this when we do surgery, our dissection is never near the bifurcation area or the proximal ICA where the plaque is going to be. So mostly we'll be dissecting away from the plaque. So basically what we do is we are dissecting is clearly a non-touch, minimal touch or non-touch technique wherein we are dissecting the body away from the vessel rather than a vessel away from the body. So what we do is we never touch around the dissections until we clamp. So the surgeon has a very good control on how we are manipulating around the bifurcation. So there is a less chance of embolization during the procedure. So once the patient is systemic heparination is given, we clamp the vessel in the order of ICA followed by ECA and CCA. We do an endarterectomy. We do arteriotomy followed by dissection of the plaque, and then we remove the plaque so that such that there is a definite endpoint we are creating in the ICA. So this is the kind of plaque we encounter when we are doing the surgery. Like we can see the angry looking ulcerated plaque, and also some thrombus is sitting over the summit of the plaque. So once it is done, we usually close the arteriotomy with a patch, mostly a venous patch, sometimes a prosthetic patch like this. And this is the specimen that routinely we get. This is the CCA end of the plaque. This is ICA, sorry, external carotid artery. This is the distal end, which is like nicely feathered in the distal, in the ICA. And this is the ulcerated plaque. So this is after the endarterectomy specimen. So now actually Sarah has shown the animation. You already know that once we the embolization can happen at any of these steps. Like first of all, whenever we put the initial catheter, the embolization can happen. And we always, as Sarah showed, we usually put embolic protection devices, and that also has to go through the plaque. So there is always a chance of embolization. As here you can see the embolic debris getting caught within the in a filter. So just to show, like the guide wire or the embolic protection device has to go through this ulcerated plaque. So anytime it can carry a part of the thrombus or any plaque material distally during the initial manipulation.
See if the slide stopped.
Am I audible, sir?
Yeah. No. I think there was a small break, a minute.
Okay, sir.
Yeah.
So my talk, I won't be discussing anything regarding TCAR. I'm just sticking to carotid artery stenting, why it is having more issues. So whether a retinal embolic protection device is really helpful. So it will usually catches most of the bigger sized embolic materials, but very finer materials less than 100 micrometer can still go through the filter course, but this may not usually cause any symptoms. But when the patient already have a cognitive function issues with a cognitive function or a poor brain reserve, it may be have a huge impact on his post-op neurological recovery. And filter can get occluded because of too much materials, and filter can get entangled into the stent if it's not properly placed. And also protection is there only during the procedure. And it has clearly shown that even after the stent is deployed, there is embolic material can still, delayed embolism can happen. That protection is not given by the embolic protection device. So these are drawbacks of embolic protection device. Sorry.
My slides are not shown.
1 second, I will share again.
The slides after the break. You showed carotid endarterectomy. You are separating the plaque from there on.
Network issue. Sorry. Is it visible, sir?
Yes, now.
So in this one of the part of this trial, what they did is they tried to see the post-operative MI comparing carotid artery stenting with a CEA. They could find that there are at least 3 times more number of new ischemic lesions are happening in carotid artery stenting compared to carotid endarterectomy. And all these patients were, most of these patients still had an embolic protection device. So this was not completely helpful. So as we know, there are a lot of randomized control trials. And again, I also wanted to concentrate on this trial because this being the recent and the largest and little bit better conducted study, I would say. And as Sarah said, the primary endpoint, there is no difference between the two groups. And when the sub-analysis was done, there is more periprocedural stroke in stenting, especially in the symptomatic patients, and more periprocedural MI in CEA. So he has already pointed out the problems. I will again go through these 3 points. Like what are the drawbacks of Crest trial? First of all, it was supposed to be only for symptomatic patients, but they couldn't recruit the number of required patients. So towards the end of the study, they started including asymptomatic patients also. Almost like just like 50% are symptomatic and asymptomatic. And we all know that asymptomatic patients, most of the patients have a stable plaque, and it is like a fibrous plaque. We cannot compare the asymptomatic patient directly with a symptomatic in the same study. That's the one drawback. Second is, as Sarah has pointed out, MI should not be as a primary endpoint, because basically we are doing a procedure to prevent a stroke. So, and also they have mainly the MI is based on the elevated enzymes. So that's the problem. And one more thing is, the patients who had stenting had dual antiplatelet. Most of them had, and CEA patient, there was no particular antiplatelet regimen. Some of them had a single, some of them didn't have any antiplatelet regimen. So this may have given a upper hand in case of perioperative cardiac events. So patient on dual antiplatelet, maybe that's why they didn't have much of the cardiac events. And when subgroup analysis was done, especially in the patients who's having symptomatic or female and more than 75% age, 75 years of age, had a better worse outcome with stenting. So what we are left out with carotid stenting has like a similar stroke rate only when it is done in asymptomatic, based on this study, with Crest study, only in asymptomatic male and less than 75. And we all know that asymptomatic patients, we are not, mostly they are benefiting only with BMT. So only a very particular subgroup of patients will have a benefit from carotid artery stenting, unlike carotid endarterectomy. And also one study analyzed whether there is any decrease in rate of perioperative events over the years. So like over a period of 8 years, there's definite decrease in both carotid stenting as well as carotid endarterectomy. The overall rate of stroke has come down, basically because of improved techniques and embolic protection device and more number of people are doing carotid endarterectomy. So overall, the results are better, but still, carotid stenting has a more perioperative stroke compared to carotid endarterectomy. So, and Sarah also pointed out the lesion-specific characteristics like lipid-rich plaque, intraplaque hemorrhage, fibrous cap. These are all mostly seen in vulnerable plaque, which is usually in most of symptomatic patients. Since we are only intervening only symptomatic patients, and most of our symptomatic patients have this kind of plaque morphology. So indirectly to say that most of the patients are not directly a candidate for carotid artery stenting. But whether we can do carotid endarterectomy in all these patients, definitely, once again, definitely there are patients who is not fit for carotid endarterectomy. Only whatever in our clinical practice also we see only these two things. One is medical comorbidities, other is local anatomical factors. So basically, in even medical comorbidities, we are very particular about the cardiac. The patient is having any previous significant cardiac issues, then definitely he is not a fit patient for a carotid endarterectomy. And local anatomical factors like prior neck operations, irradiation, restenosis after previous carotid endarterectomy are high, like bifurcation is very high up, or patient is having tracheostomy. These are local anatomical factors which is going to be a contraindication for CE. So based on this, we in our routine practice in our institute, we have a comprehensive stroke meet. We usually meet once in a month. So we discuss about all these patients who have extracranial carotid artery disease. And I will go through few case scenarios on how we are choosing these patients. Like this first patient is a 60 years old male, hypertensive diabetic, with no history of coronary artery disease, had one episode of left hemispheric TIA. In based on echo, ECG, everything is normal. CT showed bilateral ICS stenosis. Since he is symptomatic for left side, so left side needs some intervention, and there is no any contraindications for him for a carotid endarterectomy. So he is a straightforward candidate for carotid endarterectomy. So as you can see, our first option is always carotid endarterectomy, and we see if there is any contraindication for CEA, then only we go for CES, not the other way around. So coming to second case, she is a 65 years old female, hypertensive and diabetic, and she is having history of exertional dyspnea, even though there is no previous history of CAD. And echo also was abnormal, showing a regional motion abnormality. And she is symptomatic. She had a left hemispheric stroke and had a tight stenosis at the just beyond the bifurcation. So obviously, with this kind of medical comorbidities, she is not a candidate for carotid endarterectomy, even under local also. So she benefited from carotid artery stenting, and this is the post-operative. So, and third scenario is where the patient comes with history of, he is a 70 years old male, hypertensive, had a CA larynx, and he had he has a radiation for the local treatment, and one episode of stroke 3 weeks back, but now he is completely improved. Echo is normal. So even though the medically he is fit, but there is a local anatomical reason for not doing carotid endarterectomy, even though there is a tight lesion. So this patient obviously will go for carotid artery stenting. So this is how we choose in our day-to-day practice. Like when the patient is having symptomatic stenosis, the first option is, well, first we have to intervene. And if we are going to intervene, the first option is always carotid endarterectomy. If there are contraindications like either medical comorbidities or anatomical comorbidities, then only the patient is go for carotid artery stenting. So in our institute, the comprehensive stroke program was started in 2011. And since then, now last 10 years, we have done around 351 cases, majority done by Professor Unni sir, then by Dr. R.C. Srikumar sir. Mostly, whatever in our day-to-day practice, we intervene maximum only in symptomatic patients. Asymptomatic patients, as Satvik has said, those are the same indication we also follow in our institute. So our major stroke rate is around 0.8%, minor stroke or TA is around 3.4. Mostly like almost all of them improved within a day or so. And we had a cardiac coronary event in up to 3.3%. And among that, one patient has had a mortality, and other mortality is because of dense stroke. So we looked at these 11 patients, like if we can predict like preoperatively any factors which will point out the high risk of coronary events. And what we have found out is these three factors, like if a patient had a history of CAD, ECG changes and echo changes corresponding to any old cardiac event or any fresh any cardiac event. So these things are there. Definitely patient is having high risk of perioperative MI. So nowadays, if any of these factors are there, we definitely don't push the patient for carotid endarterectomy, and then mostly they go for carotid. They'll definitely go for carotid stenting only. So this is our results. So to conclude, CEA still remains the gold standard modality of intervention, and even in CEA we have to properly select the patients. So we have to select the particular modality which is going to be less morbid for the patient. Thank you.
Thanks, Shiva. I think it looks like Unni sir has just temporarily logged out. Are there any questions from the audience? Chat box is empty as of now. I think while the questions are coming in, Satvik sir, I believe the Gangaram team do a lot of carotids under local. Would you like to throw some light on how you go about doing?
Yeah. So we do all our carotids under local. I don't remember. I mean, perhaps when the last carotid under GA was done, all carotids under wakeful anesthesia monitoring, and we give a deep cervical block, which is basically along our anesthetist gives the block. It's along the posterior margin of the sternocleidomastoid, from basically the mastoid all the way to the clavicle. And it's a very effective block. We've never had a problem. And I truly believe that there is no other kind of monitoring which is superior to wakeful monitoring, because you know exactly what is happening, and while you're clamping, unclamping, you can calculate stump pressure and need to put in a shunt. So all of this is done under local anesthesia. And we've been practicing in a few cases a special kind of technique which is called modified diversion endarterectomy, which is basically an incision on the carotid bulb, which we extend just up to the just barely up to the ostium of the ICA, and then start the endarterectomy of the bifurcation and evert the plaque out of the ICA. The advantage is that since the incision is on the bulb, you don't end up narrowing the ICA, and you don't need to patch. Some of us don't necessarily patch every case. It would depend on the size of the ICA. Also, the other important thing about restenosis after carotid endarterectomy, it is believed that if at all there is restenosis, you don't have to worry about it, because this is mostly benign restenosis. Because the thing is that you are treating an embolic phenomenon. You're not treating a hemodynamic phenomenon. And if at all there is restenosis, it's usually in some amount of fibrosis and cicatrization, and only rarely is it a case of an atheroma which is growing in again. Our restenosis rates are very, very low, and we do a selective kind of patching, selective kind of shunting, and so far these techniques have served us well. But almost all carotid endarterectomies we do under local anesthesia.
Right, sir. There's a question come in the chat box. So Dr. Vimal sir is asking, in a patient with TIA, is Doppler always mandatory, or do we go straight ahead with a CT or an MR? Vineet, would you want to answer that?
If patient comes with
or can you just go ahead and do a CT or an MR angio?
No, we will do Doppler. Why? Because this in Doppler, based on this, as Unni sir also rightly pointed out, that that hemodynamic effect based on the PSV value will calculate the degree of stenosis. So next is the plaque characterization. the collucency, all these things. There are many plaque classifications are there based on that. In ACRS study, 2-3 parameters, grayscale, median, discrete white areas, all these things can be better appreciated with duplex. So duplex is a very important investigation that add on to plaque characterization. And CT angio, as Satyuk sir told, not only the site of the occlusion degree based on the severity stenosis calculation, with the relationship with the bone and intracerebral circulation in pertaining to stenting. These two things are, if your relationship to bone, whether it is below clavicle, above C2, with regard to the stenting. So both these are complementary. I think so.
Shall I add one point, sir?
Yeah, Shiva.
Basically, the Doppler helps when mainly in the moderate stenosis. Severe stenosis, CT is more than enough. In the moderate stenosis of 60 to 79% is there. Sometimes CT looks like it is not clearly 60, some 50 to 60 kind of. Then we correlate with the Doppler. So Doppler, the velocity is more than 220, 225. Then we take it as significant. So that correlation comes when the patient already has a CT, MRI, whether to do Doppler or not. That's all.
Okay.
So if I might just add my 2 bits, a great advantage of the Doppler. So normally, we do our own Dopplers, and sometimes we, particularly in patients with short neck, we use the hockey stick probe, which is the small superficial probe, to see if the bifurcation is very high. We've had a couple of instances where we've picked up a very high bifurcation on Doppler. And this is of significance because perhaps the only indication for doing a carotid endarterectomy under GA, as far as I'm concerned, would be a very high bifurcation, because those are instances where you might need to divide the digastric tendon and achieve proximal control, or if the plaque is actually progressing way up into the distal ICA. And the reason why GA is helpful, and not just GA, but nasal intubation with GA in these cases, because if you've got oral intubation, the jaw remains open. If you've got nasal intubation, the jaw can be closed, and you're able to push the jaw up and get roughly another inch of space. So that you can easily plan when you're doing a Doppler and ascertain where the normal distal ICA is, where your clamping zone will be, and if you're going to need any anesthesia help in terms of nasal intubation in GA.
Right, sir. We have posted the link for the quiz of this today's session in the chat box. I request the audience to kindly attend the same. So we'll go on to the next question. This is regarding how do we patch the arteriotomy after CEA? So is it a vein patch or a PTFE, a bovine pericardium? Shiva, what's your thoughts?
So we prefer to put only vein in our institute. So when the vein is not available, like patient would have already vein has taken for CABG, or patient is having significant peripheral vascular disease, then we go for a prosthetic patch. In our OT, the bovine pericardium is very readily available, so that we use that only. If at all we need prosthetic patch, but preferences and best I feel is always the vein. That to supramalleolar GSP rather than a thigh GSP. So what we have seen also is supramalleolar malleolar GSP is little thicker than the G. There will be some venous fibrotic tissues will be there. So it is always thicker than the thigh vein. So we always take a 5 centimeter supramalleolar vein.
Right. Another question is what is the role of DSA with contralateral occlusion with balloon prior to doing a CEA? Is there anything? Is that necessary? Would you want to do that? Either CEA or CEA to test the patency of the circle of Willis, I presume. Shiva.
Sir, actually DSA as investigation should not be done prior to CA. That's whatever it is. It should not be diagnostic in investigation. That's what I feel. And there is no role of DSA in a contralateral occlusion. Since our institute we shunt all the patients under GA, so we have never seen any issues. And what we have observed is we have done around 52 and 51 cases we have done of contralateral. So what we observed is we routinely measure the stump pressure after putting the shunt only, obviously. So the patients who are having contralateral occlusion, they're having the stump pressure is definitely lesser than the other patients. So we feel it warrants a shunting when you're doing a G. That's the thing. It's a bigger controversy. I don't want to bring that here, but I don't think there is a role of DSA in a control. It's okay.
I would agree with that. I would agree with that 100%. Look, any arch and cerebral angiography is fraught with risk of peri-procedural embolization. Okay, so you shouldn't fool around with the arch and the arch vessels unless it's absolutely essential. One of the indications, obviously, when you're considering, and which is why this is important, and a lot of people actually, when you're getting the patient investigated for carotid artery disease, you should make sure that even if you're getting a CT angiography done, you should make sure that the origin of the arch vessels is included in the study, because you want to find out the debris and the atheroma at the ostium of all the arch vessels. And which is why an MR angiography is not a very good choice, because you cannot study the quality of the plaque in the ostium of the arch vessels. You don't know what calcium you're dealing with, what is the kind of plaque burden you're dealing with. That's number one. And number two, perhaps in my view, the only indication for a DSA, which is diagnostic, would be if you are not too sure what is happening in the cerebral circulation. If you've got significant bilateral disease or perhaps a one-sided occlusion, thrombotic occlusion, but getting an infarct on the other side. So just to see what dynamic circulation is happening in the brain, you might need to do a DSA. But I completely agree with Shiva that routine DSA is not to be done.
So sometimes when we look at the intracerebral circulation, you may see a significant lesion in the intracranial arteries as well, probably on the same side as the symptoms are. How do we decide whether we should do the proximal lesion, or probably it's a distal lesion that is the culprit in such patients?
Yeah, so my sense is that I think it's always a combination of investigations. I would say that if you're going to touch the carotid, you need a combination of both Doppler and CT angiography. I would not subject the patient to an MR angiography unless the creatinine is deranged. And the reason is because you would want to study plaque characteristics. You would want to not just the echolucency of the plaque, but if there is any ulceration. If you find that it's a perfectly stable plaque at the carotid bifurcation, a very calcific and stable plaque at the carotid bifurcation, but you've got a soft plaque in the intracranial ICA, then the incriminating lesion will be the intracranial one, and vice versa. If you've got a stable plaque, usually intracranial ICA plaques don't embolize. If you've got tandem lesions, what happens is that the first lesion, which is in the neck, the carotid bifurcation, the velocities are so high there that any debris that's going to be dislodged will be dislodged from the neck, and there'll be a sudden decrease in velocities after that. So usually velocities are not that high in tandem lesions in the second lesion to cause embolization. So it's usually the first plaque that is responsible, but of course you should study plaque characteristics and then decide which is the incriminating plaque.
So one more thing is when the tandem lesions are there, the distal lesion, because of the proximal tight, it looks like overestimated. It may look very tight, but it is not actually very tight. And we saw our own series, like when the patient is having tandem lesions, the follow-up, the vessel is looking, it's not like so tight. So that's how our observation. So, and since we have only, we can manage only the extracranial carotid artery disease, if it is significant, I think it has to be done. some neurologists are doing, I think, intracranial stenting also. That is. Undi sir has joined again, sir.
Yeah, we had some electricity problems, it's got corrected. We have not found out the reason, but we have shut them off. And I missed some of the, can you hear me now?
Yes, sir.
Yeah. So, in fact, what I wanted to say was that for both, like for example, for the carotid endarterectomy, there are specific indications, and then for stenting, which is a complementary procedure, I myself list about 6-7 indications for stenting that we all know. Number one is restenosis. I wouldn't want to reoperate. It is fraught with problem. I may end up with losing the carotid. It will be a messy surgery. C2 bifurcation or very high bifurcation. Again, it's not accessible. It's not good to dislocate temporomandibular and all those gimmicks. It's not going to help. I would leave it. Third thing is the patient is having very poor ejection fraction, unstable angina, then he is for stenting. Then contralateral recurrent laryngeal nerve, it is a little frightening because in case something goes wrong, if anything can go wrong, it can. So contralateral recurrent laryngeal nerve, I will not operate because if you knock out both recurrent, it can be a problem. Then of course, if the patient requests and he doesn't want surgery, that is fine. When you come to the stenting side, if it is something like 98% or 97%, very thin hairline continuity, it may not be an easy access to cross. Even multiple crossing is going to push up things, especially symptomatic, vulnerable at ulcerated plaque is a little dangerous. I have done one doctor who had a stroke for a day, then recovered, like RIND we call, good old RIND, minor stroke. Then somebody tried to do a stenting, they could not find, they could not cross. He came here, he has had here, I think he had some oral carcinoma, had radiation. Then I had no choice, through radiated neck, some difficulty, it took an hour and a half to get onto the carotid. I could successfully do it. So it's not an absolute contraindication. I was forced to do it, so we could do it. Secondly, if the arch anatomy is so bad in terms of severe atherosclerotic disease and or the vessels originating in very awkward tortuous way, that will not be a facilitating point for stenting. So these are the two things I would say. We should consider patient in a whole, the plaque in a whole, the carotid artery disposition, then choose the best procedure for that patient and the lesion. So as Satvik said, I can only reiterate that it's a first, second, and third indication will be for endarterectomy. I mean, for stenting, in my mind, as a strong interest in open surgery, I would rather do surgery because you have to make a lot of trespassing through the ulcerated plaque before you can pass lines. And secondly, even though you have a basket there to collect the debris, only when the circulation restarts, things will fly. If it is blocked and then you are not reperfused, it is held on. And there will be something little loose like tissue, which can go when the circulation and the BP comes up with a good amount of reperfusion to the brain. So I feel you have to choose the procedure for the lesion and for the patient first, and then exclude stenting for very bad aortic anatomy, the loop carotid artery. We had a 360-degree loop carotid artery with 80% symptomatic. Obviously, we resected the entire ICA from its origin, the isthmus, and then replanted. So we have to consider the patient and the lesion. And the other question for the benefit of the residents, if we have, the question is if you have asymptomatic 80% who is going for coronary artery bypass. So there the problem is it is better to do that side carotid endarterectomy followed by CABG same sitting, because with the perfusion pressure reduced to 50 or 60, with the full heparinization, there can be hemorrhage and that can precipitate a stroke. That is one. And for the other point of bilateral incidental asymptomatic, then it is better to do CA with CABG on the left side. The dominant hand is right, and you have the Broca's area on the left side. So to preserve speech and right-handedness, it's better to do on the right side if it's equal on 80%. Otherwise, I think the both are complementary procedures we have to consider. And I'm glad Satvik can do both, but I don't think I can do both. We have to get, with the help of cardiologists or mostly interventional radiologists, Sri Chitra, for the stenting. But then with the advent of the way, I think I remember 2015 when I was there, we did 52 carotid endarterectomy, one stenting. I think the situation will be more or less similar with Shiva these days. Anyway, I think I congratulate all the speakers, Vineet, Satvik, and Shiva. I think congratulations and very well done. I think it is much better than a conference talk because it's been comprehensively covered, masterly covered. Thank you so much.
Thank you so much, sir, for those.
Thank you, sir. Thank you very much.
Thank you.
Sri Kumar, sir, would you like to add certain points, sir, with your experience? Sri Kumar, sir, are you there? Probably he's not in line. So if there are not any more questions, shall we wind up the session, sir? Only, sir?
Satvik?
Yeah.
Nice talk. I just want you to emphasize more on how to identify this vulnerable plaque by ultrasound, because what do you think is the most ominous sign to say this unstable plaque and you need to really intervene?
So if you, single word answer would be echolucence. The more lucent the plaque, the lighter the plaque on ultrasound, the more dangerous it is. And as I said that, you have this intravascular contrast, which we use, which are a set of micro bubbles, which we use, which you inject, and then you keep the probe on the plaque, and you activate power Doppler. If you're able to locate these bubbles within the substance of the plaque, that means there's increased vascularity in the plaque, which is a very dangerous sign. So also on Doppler, it's a superficial artery, so you can very easily appreciate any crevices in the plaque, any ulcerations, any irregularities. It's very, very easy to pick them up. If instead you find a lot of calcium, then you would characterize that as a stable plaque. The important thing is that also what side the calcium is. If the calcium is on the adventitial side more and not towards the side of the lumen, then it's not helping the plaque, because the rupture is going to take place on the side of the lumen. So if the cap of the plaque is loosened and more loosened towards the luminal side, that is a dangerous sign, even if it's a mixed plaque.
So if it's an unstable plaque, would you intervene in a patient with less degree of stenosis?
So asymptomatic, as I said, I am very careful. I normally wouldn't do stenting in asymptomatics. I would only do endarterectomy, and I would touch more than 80% if the life expectancy is more than 5 years, and that too if it's a vulnerable plaque based on the criteria I've described. More than 80% vulnerable plaque, life expectancy more than 5, carotid endarterectomy.
Okay, I think Siddha, there are 2 more questions in the chat box.
Yes, sir. Dr. Rajesh has asked how often would you use shunts when you do carotid endarterectomy in the local? Satvik, sir, do you use shunts?
So very selectively, as I said, you can either measure stump pressure, but wakeful monitoring is a much, much better technique. You basically, the patient is conscious, the anesthetist is constantly asking him or her to, press on the hands, and you're monitoring everything. So in case you find any deterioration in function, any obtundation, you can immediately shunt. Our shunts are ready, but we find that our if with modified diversion and arterectomy, our clamping time is usually on an average, between about 12 to 14 minutes or 10 to 14 minutes. So we don't really need to shunt. Even when we are patching or doing primary closures for large ICAs, even then our clamping time is not very, very high. I'd say 1 in 12 to 15 is our shunting rate. If you're doing, once in about 15 cases have we felt the need to shunt, or even lesser actually.
If you were to do it at a GA, would you still not shunt? Or?
No, so then I would definitely check stump pressure. No, under GA there's no doubt.
Right.
But selective, I don't shunt all. I'm very clear. I mean, shunting has its disadvantages, so I wouldn't shunt all. Yeah.
No, in fact, I just want to add one thing, that I think the true requirement of shunt is not 100%, definitely not. But we are used to putting 100 every case. We used to put shunt because we are trying to prevent stroke in every single individual. So we would rather take all precautions. Then we have no hard feelings, number one. Number two, we take this 5-6 minutes to remove the plaque and put in the shunt. Then we have an opportunity to use a vein patch, which takes a little trickier than a prosthetic patch or a Gore-Tex patch, which will be straight and this will be wrinkling. And I have developed a technique of how to cut it in only limited way and then put the patch onto the the carotid artery. So I feel you can do peacefully 20-25 minutes, take it and then a good patching. And that is number one. And I remember long time back, 20 years back, I read an article by Crest and Pruy, who along with the, Inera came up with this shunt. He says his total number of endarterectomies are 5,600. Those days, one of the highest in the world. And he mentions there are many hundreds in between where there was not even a single stroke. And he, obviously, as a proponent, he used to use Stent. So I'm happy that we have not a major stroke because of our problem. Only one intracerebral hemorrhage that I remember. Otherwise, for 100 cases, we have not even had any stroke. Some TIAs, which they have recovered from by the time in 2-3 days of treatment. So, and then it's very important to, to help your colleagues work up without any tension. They can do comfortably, and there's no problem. All I used to say is stand with Ajay or Siddharth or our Shrujal or whoever, more than 10 people. I used to stand on the side, but they used to do very well. Because there's time, we are not against clock. No procedure. Even if you take the time, 12-15 minutes you take to do the eversion, that much, say 10 minutes we can take to remove the plaque and put in the shunt. Once you put in the shunt, it is aram se, there is no hurry, you can do. And I think it's easy for the consultant you train as well as the younger colleagues to do it comfortably. And I still hear Ajay, Shrujal and all, they put shunt and they do it their own way. There are many ways of doing, but I think this is something, for a single procedure and lesion, I follow one technique because there are so many things that you have to be looking at. So I feel it is safer. Another thing is that there are some few indications you must use shunts. Number one, if they had a major stroke and recovered, it is a little tricky not to put a shunt because that this opposite side contralateral carotid flow may not be supplying proximal to the block if there is a block there. Plus, of course, stump pressure, we know less than 30 or 40. But again, you cannot make out that, there cannot be a hypotension, some allergic reaction, some bleeding. So we don't know what, there will be a little bit of hurry. And in one incident only, I remember there was subclavian stenosis which was not identified. We found after putting shunt, the pressure 120 in the right radial and the shunt pressure was 160. That was one story out of so many. So personally, I feel for everybody is good, mostly for patients. I think putting a shunt, at least in the beginning, then perhaps once you have done 50, 100, you could slowly decide which one may require and you can take some freedom. But I think we need not take freedom. with the patients. I feel, at least that is my attitude. But obviously there are so many, 80% of surgeons don't do shunts. So I guess that is fine as well.
I have my opinion reservation regarding shunt use. When we started Chitra, initially I was using shunt for all the patients. Then later, I've done few cases of CE under local, and our observation is that by 11th or 12th minute, patient showed developed some sluggishness in his activities. So it's even though it's completely clamped for the first 10 to 11 minutes, there is no neurological deficits at all. There's no neurological deficit in the activity also. That means that our inference is, so if you are doing a procedure within that period, there is no need of a shunt. So then we shifted to eversion completely. And during eversion, that's again my observation is, if we can finish the eversion procedure in 3, 4, 5 minutes, and if we can finish anastomosis within 10, 11 minutes, so no shunt is required for this patient. So we have done. So now we are doing all the cases with eversion without shunt, and we haven't met with any stroke. Other thing is this: if you are after eversion, if you are trying to put a shunt, it will take another 3 to 4 minutes, and it will take another 2 to 3 minutes before you finish the anastomosis for removing the shunt. So in fact, even though you are using the shunt, at least 5 to 6 minutes will be required to remove the shunt and putting the shunt. So if you're okay with the anastomosis, we can finish anastomosis that time. So from my experience of using shunt, then selective shunt, now in a no shunt stage, my opinion is regular shunting is not required. Of course, okay, high-risk patient, or if you are not confident about the anastomosis or a poor vessel, then you can go for a shunt. Otherwise, a routine shunting is not required. That's my opinion. And highly selective shunting is what is required now. Routine shunting, it will take more time rather than doing the anastomosis, particularly if you are doing an eversion without shunt. So that's my suggestion.
No, I do appreciate. I think definitely that's definitely a viewpoint. Now, there are two things about this. Experienced surgeon like Dr. Sri Kumar doing and changing over is different from, in a teaching hospital where the youngsters are starting. Actually, carotid endarterectomy, I used to be very tense in first 10, 20, 30, 40 cases. After seeing that, we knew this was very secure, and I hate doing under local, the patient talking to me. I don't want to be talking to the patient when I am doing carotid endarterectomy. See, we got one good chance to prevent stroke, and that's not the time to talk to him. I have enough time to talk to him before and after. So I just want him to be sleeping, and I feel more nervous than him going through a local procedure. I mean, that's the difference between the surgeon's approach. There are, of course, I do agree, local can be done. An experienced surgeon can train himself and do differently. But I feel at least the first 50 cases by the younger colleagues, it's
Sir, a beginner, the carotid dissection is more with, if he is not well versed, is using a shunt. There are case reports of carotid dissection also using the shunt. So unless he is very much experienced for putting a shunt, shunting may be more harmful than without using a shunt. That's my opinion. So
that is acceptable. That is, it is there. Because there is no procedure is, there's no easy lunge or free lunge. Everything you do, it has got a potential. Only thing is the Inera Prui siliconized shunt, if you maneuver gently, the jagged one can start a dissection, that can push things. But we should use a Inera Prui, which is very soft, dip it in a little bit of saline, and you can easily thread it according to the, and generally we use a 9F shunt, and we get a, we monitor the, that's stump pressure also, that is the shunt pressure also we monitor. It comes to something like 60 to 70% of the systemic. I mean, there are multiple ways of doing. I think quite agree. I can accept and appreciate your discussion as well.
Thank you, sir. We are a little late. So if any more question, if no more questions, we can wind up.
Yes, sir. I think
Yeah.
we understand.
Anything else?
Yeah, so I think it has been a great discussion.
I think I just need to just say one thing. I think Siddharth needs something. We cannot give a standing ovation, but at least a clap, because he was the man who actually orchestrated the whole thing, and to his position and all the nitty-gritty things of the whole program was done by Siddharth, basically, for coordinating, for making the whole idea, inviting speakers, etc. I think he needs a special mention in this, and especially thanks Atul for being the speaker for today, because it was a great talk.
My honor and my pleasure entirely.
Yes, I think, really
So I think it was wonderful.
Gets better.
So I think it was wonderful. And also Shiva and Vineet, the first presentation made one of the best presentation. Congrats, Sid, for conducting the whole sessions. He took all the pains to organize these, organize faculty. Vineet, I know you are very busy.
Support of all of us in VASK. You as the president, Vimal sir, Sunil sir, everybody has pitched in. Shiva has done great work with the quiz. Everybody's done. I mean, what I'm really glad is that all of us in VASK have participated in this webinar. So it has been a truly unanimous effort of the entire society. So I'm really happy for that. So I
request some comments from Vimal. Vimal has organized all the money for this session. But he's always standing behind or sitting behind. Vimal.
Yeah, thank you, sir. Thank you for the appreciation. Thank you, Satvik, for joining us in this last webinar series. Great to see you around. Hope you are all doing good and safe there.
Thank you.
Will wants to show you something?
No, just wanted to, as we are winding up on the webinar series, before you conclude, I just wanted to tell two things. One is that on this talk, one thing we come across our daily practice, and very often we neglect, or what we see is being neglected, is the extracranial carotid artery. The physician or neurologist or whichever patient sees a patient in a TAF stroke, very often an MRI stroke protocol is ordered. And very often, as Satvik correctly pointed out, the ostial part of the carotids and probably the bifurcation is not seen through. So that's what probably has been highlighted in the discussion, that a Doppler is also complementary unless a CT angio is done. Well taken. Thank you everyone from VASK for being with us, especially Siddharth, our sister, and all our team members, including Sunil and Shivanation. Well conducted quiz programs, and the postgraduates taking it well. I think we had even nephrologists winning the prize last time. The entire series, starting from veins, arteries, AVF, masonry, and ending with carotids, was nice. I think we'll continue to pursue this program through some PG clinics and sessions. Thank you once again, and I think Unni sir wants to add something. Please, sir.
Yeah. I think that actually, I also would like to congratulate Siddharth, Sunil, yourself, and Sri, because you got the idea, you put it through. It has been wonderful. And to just give an opinion and idea about what Vimal's mentioned. See, the point is, in 1997, September 23rd, I did my first endarterectomy. Every year it should be 2 or 3 or 4. Out of the 4, 3 used to be referred by outside neurologists. Only 1 by 10 neurologists who are working in Sijitra. They were not convinced. Now we formed a stroke team with the leader as the stroke neurologist, radiologist, vascular surgeon, and resident. We conducted a good meeting. Every patient coming with carotid symptoms or carotid disease detected used to be discussed. So the crux is, the point is that you should form a team, including all the relevant people, neurologists as the lead, and discuss. And then that is how you could really improve and get to do whether stenting you want to do, carotid endarterectomy. I can tell you 2 to 3. And when I wrote the article, which is in PubMed now, in the neurology journal also, we had done 39 cases. Then that brought a lot more patients from Kerala neurologists. then in 2015, we could do 52 endarterectomies. I feel still very happy. Last 3 years in a private hospital, I have done 10. Cases are less. I think the bottom point is form a team, then I think we will get to know and get to benefit the patients, women. Just keep it.
Thank you, sir.
Anyway, thank you very much for making me the, for the chair. And I would, if Siddharth had not told me, the last 2, 3, somehow I missed. Last one, I wanted to do that mesenteric revascularization, but that day I forgot, I got some calls. And so this one, thank you for putting up me as the moderator. And I enjoyed it. And it's been a very good learning for all of us.
Thank you, sir. So we
Thank you, sir. Thank you for being here.
We have a YouTube channel for these webinars, so we have posted all the recorded sessions in them. If anybody is interested to view them later, they can just click on the
I think, Siddharth, one more thing. I think I will see, I'll talk to our Sumit and Vijay, whether we can add as a separate chapter like the VASK webinars in the VSI website.
Yes, sir,
I think it's been going very well, and we have had national speakers, at least 1 or 2 per topic. And I think the talks were extremely good for postgraduate, good for anyone who has undertaken and listened to it. I think you make it as a webinar VASK under the auspices of VSI, and then be prepared for it, and then we will add it in the VSI. I think it's worth it. It's really, really good. And all the team members, VASK, Srikumar, Vimal, Sunil, and in particular, Siddharth, a wonderful job. Wonderful job.
Okay, thank you, sir. Definitely, VSI can take it up at national level. We all give all supports possible. And I request everybody to visit our YouTube channel and like it and subscribe it, so that will give more mileage to VASK and the YouTube. All the talks are uploaded there, as Siddharth said. Siddharth has taken all the pains to record everything and uploading into it. So I request all the VASK members and all those participants to visit and like and share our YouTube channel. All the recordings are there. So that will be good for the association also. So,
bye-bye.
Can we wind up the session?
Yes, sir. So once again, thank you all for joining us today.
Okay, sir. So I request Vimal to say if we need any comment, not on carotid, something on the VASK. Shiva, you something? Shiva is the quiz master, not on carotid, please. Shiva, please. Sandeep. Yeah, please.
Program, I think, and almost customs very in a systematic way.
Sandeep is there?
Very nicely presented, sir. Very nicely done, sir. We are really enlightened, and nice to see such programs, sir. We would like to see some more. Really encouraging.
Definitely, I need your help because we are conducting the PG sessions maybe after a month. So you'll be an invited faculty for that same PG case discussions. I need your PGs also for the same. So definitely I'll be happy to be here. You have here. We need anything?
Yes, sir. Thank you all. Good to see you. And thank you, sir, all senior faculties. Yeah, nicely organized, well organized. Even I couldn't attend many sessions, but
you're so busy. I know.
Thanks.
You're so busy running from hospital to hospital.
Sir, but alone. So that's the problem. So
okay,
I have to bring it up as a department. So
yes, Sunil is a backbone of this program. Sunil, any winding up comments? Or former secretary?
No, I already told it's a nice program. Actually, much well accepted. I think congratulations to the whole team. It's a teamwork. So
I see Vivek Agarwal.
Sir, good evening, sir.
Aranda, how are you? You are in Aranda or Bangalore?
Sir, I am in Bangalore, sir.
Bangalore.
Okay,
yes, sir. Yes, sir.
By now. Okay,
sir. Sir, I attended many sessions. And they were actually very useful, and they are, it's a very good thing for all the surgeons and especially vascular surgeons and younger colleagues. Actually, the level was very high and very good, sir. And I also want to be the part of the team whenever they start new, sir. If they can.
Yeah, sure.
Thanks, Vivek.
Yes. It's a very
Any comments?
very...
Final comments?
Sir, before Satvik leaves, can we have just Satvik, can you give any valuable suggestions? We are planning to have few clinical sessions on aiming at surgery and vascular surgery postgraduates. Any suggestions how we go about it? You are a teacher for a long time, I know.
Well, no, perhaps what we could do is, have some way of looking at some original papers that have been published in the Indian Journal of Vascular and Endovascular Surgery, and perhaps have a guest session by one guest speaker, elaborating their details about their original work. And particularly if that would be an interesting way forward, because I think we need to really strengthen original work coming out of India.
Yeah.
And which is also a way of generating data, registries, a way of generally philosophically thinking about every kind of pathology that we're dealing with. So that would be my only suggestion. And that also encourages youngsters to take up research.
Yeah, thank you.
Registry part we have started. Actually, in fact, I had presented in Hyderabad conference. Following that, now PC has already made a good protocol for carotid disease. I think that will be soon circulated, and we will be getting on with AAA and whatever the index procedures. So that registry part will be okay. And the best way to go around for research work is give good topics to informed and thoughtful topics to the postgraduates. When they work 2.5 years on, and the seniors, like most of us, can give them guide, they can read up, and then it may be some 20 or 30 or 50 cases, but that can be a very focused thing. Such papers can be already. VSI is started working on it, best paper awards, and that will be accepted for the journal. Those things are happening. So registry is happening. I think it takes time. It will be there. I think I'll ask Gupta that it can be sent to all the teaching institute, all the surgeons who are active, the registry modality, both inclusive of endarterectomy and stenting. That's already there. I think we saw it in the last EC meet about 2 weeks back.
Okay, thank you, sir. I request Sidhu for a final comment, then we'll go for vote of thanks from Vimal.
Yes, sir.
So, last comments.
Yeah, I think today's session was very informative. Lots of fully covered aspects of carotid, right from how to select a patient to going through endarterectomy and the endovascular procedure. And we are quite clear that in most cases endarterectomy is the first choice and the way to go forward. And select patients, we go for the endovascular therapy. So thank you, Unisa, for moderating the session and your words of wisdom. The speakers, Vineet, Satvik sir, and Shiva. Satvik sir, special thanks to you for joining us today. And I know it's troubled times in Delhi, and I hope and pray that we all hope and pray that things improve soon. And thank you all the audience for joining us today, and hope you have gained a lot from this session. So Vimal sir, for your final comments. And
okay, thanks Sid, for the wonderful sessions and organizing everything. I request the Secretary of VASK, Dr. Vimal, to say a lot of thanks, not only for this session, but the whole session. Then we'll wind up.
I think thanks has been, thank you, sir. Thank you, everyone. I think Siddharth has already told the gratitude and thanks already. Anyway, thank you, Unikrishnan sir, for moderating this session, and Satvik for joining us for last session. I think we'll continue this efforts to take the awareness as well as academics through as to our surgeons, postgraduates in training. So we'll be back soon with our PG clinics on is being revamped. We'll launch the website also soon. So thank you all and good night. Stay safe, all of you.
Right. Good night.
Life be busy, boss.